This year I had the pleasure to present data of our single center study assessing cryopreservation and outcomes with cryopreserved grafts in patients undergoing allogenic hematopoietic cell transplantation. As you all know, graft failure is a rare occurrence. In 2020, in our center, we observed a cluster of graft failures. Also in 2020, cryopreservation of allogenic donor apheresis products was implemented to overcome the challenges of donor availability and product transportation, which was related to the COVID-19 pandemic. Given the unusual high rate of graft failures, we decided to conduct these retrospective studies and basically compare outcomes of cryopreserved and fresh grafts at our center. We were able to identify 29 patients who undergo cryopreserved allogenic stem transplantation, and we also were able to compare those patients to a control cohort of 60 consecutive patients. They all received allogenic hematopoietic cell transplantation following either myeloablative or reduced intensity conditionings. There were some differences between the groups, with the major difference being that the cryo group included more HLA-matched unrelated donors, and the fresh group included more HLA-matched sibling and more haplo and HLA mismatched donors. Another important difference in the groups was that the median post-collection dose of CD34 positive cells per 10 to the 6 per kilogram was slightly lower in the cryopreserved versus the fresh group. What we were able to see is that in the cryopreserved group, we had 4 graft failures as compared to only 1 graft failure in the myeloablative group. Interestingly, all primary graft failures in the cryopreserved group were with reduced intensity conditioning. We also were able to see delayed engraftment of neutrophils and platelets in the cryopreserved groups. And when we looked at the overall survival, what we were able to identify is that patients undergoing reduced intensity conditioning and cryopreserved allogenic transplantation had inferior overall survival in both univariate and multivariate analysis. We also decided to look at the graft composition, as we believe that these differences in the clinical outcomes might be attributed to differences in the biological graft composition. So what we did is that we collected cryopreserved grafts, which we were able to analyze by using flow cytometry. And we compared this analysis with fresh grafts that we were able to prospectively collect at our center. As of now, we have data only on 5 cryopreserved and 4 fresh samples. But what we were able to identify is that the NK cell population significantly differ in those grafts, with cryopreserved grafts having lower absolute numbers of NK cells. So in conclusion, our study showed the inferior outcome of reduced intensity conditioning allogenic hematopoietic cell transplantation in patients basically receiving cryo-allografts. And we were also able to show data which were previously reported of delayed hematopoietic recovery in allogenic hematopoietic cell transplantation recipients receiving cryografts. Our study had several limitations. The one was that we had a small number of patients. There were imbalances between 2 groups, and we have also shorter follow-up of the cryo cohort. Strength of the study was that patients were consecutively collected, which basically should minimize selection bias. We focus in the future to study and examine more into details the graft composition of cryopreserved and fresh grafts, as we believe that this might play a role in the differences we see in clinical outcome.